A 32-year-old woman walked into a hospital with two diagnoses that seemed all too familiar: migraine and bipolar disorder. If the investigation had stopped there, she might have kept going back and forth between neurology and psychiatry. But magnetic resonance imaging, or MRI, revealed something that could not be ignored: large, symmetric, confluent abnormalities in the white matter of both cerebral hemispheres. Her neurologic exam also revealed bilateral pyramidal signs. Why would an adult have MRI findings that looked like a leukodystrophy? In the end, 3 metabolic markers changed the entire direction of the investigation. The condition behind these unexplained findings was an inborn error of metabolism, or IEM, glutaric acidemia type 1, or GA1. Chapter 1. The headaches that began at 17. This adult case was published in the New Zealand Medical Journal in 2015. Act 1. The first warning. The first warning had sounded years earlier, when she was just 17. That was when her migraine headaches began. Over the years, they gradually became worse. She also carried a diagnosis of bipolar disorder. The documented change in her mood came after GA1 was diagnosed and treated for 3 months. The case report stated that after treatment for GA1, her mood improved. Her mood swings became less frequent, and her migraine episodes decreased. But before the doctors could reach the treatment stage, they needed stronger evidence. Act 2. Neurologic abnormalities appear beside a psychiatric diagnosis. The investigation began to change direction because of several small but very specific clinical signs. When the doctors tested the reflexes on the soles of her feet, they found that both plantar responses were extensor. In other words, she had bilateral pyramidal signs. This suggested that the central pathways controlling voluntary movement might have been affected. That finding could not identify a specific disease on its own, but it was enough to warn the doctors this might involve more than migraine and mood symptoms. There was also a subtle abnormality in her eye movements. When her eyes followed a moving target, the pursuit movement that should have been smooth became broken and irregular. Her rapid eye movements, known as saccades, were normal. Her binocular fusion was also normal. The report did not describe double vision, nystagmus, or loss of vision. In other words, not every aspect of her eye movements was abnormal. The main abnormality was in smooth pursuit. What made the case even easier to underestimate was everything that appeared normal. Her muscle tone was normal. Her muscle strength was normal. Her deep tendon reflexes were also normal. There was no known family history of neurologic disease, but those normal findings did not erase the bilateral pyramidal signs, and a negative family history does not rule out an autosomal recessive disorder. Act 3. MRI turns the scattered clues into a map. Once the MRI appeared on the screen, the nature of the case changed. This no longer looked like an ordinary case of migraine, and it was difficult to explain with a psychiatric diagnosis alone. Her T2 weighted and fluid-attenuated inversion recovery, or FLAIR, images showed large, symmetric, confluent signal abnormalities in the white matter of both cerebral hemispheres. They mainly involved the subcortical white matter of the frontal, parietal, and occipital lobes. There was also mild cerebral atrophy. The lesions showed no restricted diffusion. There was no enhancement after contrast administration. But the most distinctive clue was hidden on either side of the sylvian fissures. Both opercula were widened. The sylvian fissures and the cerebrospinal fluid spaces in front of the temporal lobes were unusually prominent. In GA1, this imaging pattern is often seen with frontotemporal hypoplasia, meaning underdevelopment, or with atrophy-like changes. There was also one crucial contrast. Her basal ganglia appeared normal. In classic infantile GA1, an acute encephalopathic crisis often causes injury to the striatum. Children may be left with severe dystonia and other movement disorders. But this adult patient did not have that imaging pattern. Her abnormalities were concentrated in the white matter and the frontotemporal regions. That pattern was closer to what has been reported in some patients with late-onset GA1. Act 4. Cognitive testing adds another piece beyond her psychiatric symptoms. Neuropsychological testing revealed two more abnormalities. Her verbal fluency was reduced. Her motor sequencing was also impaired. In simple terms, she had difficulty rapidly retrieving words according to a set rule and organizing a sequence of consecutive movements. These findings suggested that functions associated with the frontal lobes might have been affected. They also echoed the frontotemporal changes seen on her MRI. The doctors were no longer looking at two isolated diagnoses. They were looking at a connected group of clues, a history of bipolar disorder, migraine headaches that had progressively worsened, abnormal results on tests of frontal lobe function, bilateral pyramidal signs, abnormal smooth pursuit, and widespread symmetric white matter disease. So the medical team continued the investigation, looking for a white matter disorder or an inherited metabolic disease. Act 5, the first round of tests, is almost entirely normal. The doctors first tested for several conditions that can cause white matter abnormalities. Plasma lysosomal enzyme studies were normal. Plasma amino acids were normal. Blood lactate was normal, and very long-chain fatty acids were also normal. These results helped narrow the possibilities, but the investigation could not end there. A negative screening test can make certain diseases less likely. It cannot prove that every inborn error of metabolism is absent. The real breakthrough came from urine organic acid analysis. Act 6. The metabolic fingerprints appear. Her urinary glutaric acid level was 857. In that laboratory, the normal value was below 4. Her urinary 3-hydroxyglutaric acid level was 44. The normal value was below 1. Two metabolites closely associated with GA1 were markedly elevated at the same time. The diagnostic possibilities suddenly became much narrower. Then a third fingerprint appeared in her blood, plasma glutarylcarnitine, or C5DC. Her level was 1.2 micromoles per liter. The reference value in the case report was below 0.34. Elevated urinary glutaric acid, elevated urinary 3-hydroxyglutaric acid, elevated plasma C5DC. All three findings pointed to the same blocked metabolic pathway. But abnormal metabolite levels mainly help narrow the direction of the investigation. Definitive confirmation still requires genetic or enzyme-based evidence. Genetic testing then found two abnormal alleles in the gene that encodes glutaryl-CoA dehydrogenase, known as GCDH. She was compound heterozygous for two GCDH variants. At last, her clinical findings, MRI pattern, biochemical results, and genetic results formed one complete chain of evidence. The diagnosis was confirmed: Glutaric Acidemia type 1, GA1. Act 7. Where was her metabolic pathway blocked? The problem in GA1 occurs in part of an amino acid breakdown pathway inside the mitochondria. The GCDH gene provides instructions for making an enzyme. That enzyme is called glutaryl-CoA dehydrogenase. This enzyme system is involved in breaking down lysine, hydroxylysine, and tryptophan. When glutaryl-CoA dehydrogenase does not function adequately, the pathway becomes blocked. Glutaric acid, 3-hydroxyglutaric acid, and C5DC then rise. So the abnormalities in her urine and blood were not unrelated coincidences. They all came from the same metabolic bottleneck. Glutaric acid and 3-hydroxyglutaric acid are diagnostic clues. They are also thought to contribute to neurotoxicity, especially to striatal injury in GA1. However, this single case cannot tell us precisely how her white matter disease developed. That distinction matters, and it requires medical caution. Act 8. How did GA1 remain hidden throughout her childhood? She did not follow the classic course of GA1. Classic cases often present during infancy or early childhood. An infection, fasting, or another form of catabolic stress can trigger an acute encephalopathic crisis. After that crisis, a child may develop striatal injury, dystonia, and severe movement disorders. But this patient's medical record did not document an acute encephalopathic crisis during childhood. It did not document dystonia or Parkinsonism either, and her basal ganglia remained normal. But none of that ruled out GA1. The clues in late-onset GA1 are often much more scattered. Patients may develop chronic headaches, pyramidal signs, abnormal eye movements, cognitive changes, or white matter disease. Some patients may have almost no obvious symptoms at all. So when GA1 does not follow the textbook pattern, it can remain hidden until well into adulthood. Act 9. What happened after 3 months of treatment? After the diagnosis, her doctors added LeuKarnitine. The dose reported in this case was 100 milligrams, 4 times a day. Her plasma carnitine levels were monitored at the same time. Please keep one point in mind. This was the individualized prescription used for this particular patient at that time. It should not be copied for another person with GA1. And it should never be treated as a general therapy for migraine or bipolar disorder. LeuKarnitine can bind to some abnormal acyl groups. This helps form acylcarnitines that can be transported and excreted. It also helps maintain the intracellular balance of carnitine and coenzyme A. She was also taking propranolol. The dose was 10 milligrams twice a day. 3 months later, the case report documented 3 changes. Her mood had improved, her mood swings had decreased, and her migraine episodes had become less frequent. The report did not fully describe her other psychiatric care or her long-term metabolic management. If information was not included, all we can say is that the case report did not provide it. We cannot assume that she definitely received that care, or that she definitely did not. Ending the real danger is stopping the investigation too soon. This case does not mean that everyone with migraine or bipolar disorder should be suspected of having GA1. Both conditions are common in the general population. GA1 is very rare. What deserves further investigation is an unusual combination of findings. Beyond the migraine, there were bilateral pyramidal signs. Alongside the psychiatric history, there were abnormalities on tests of frontal lobe function. And on an MRI obtained in a patient with headaches, there was widespread, symmetric, white matter disease. Then there were the widened opercula and the frontotemporal changes. Those objective findings could not be fully explained by one common diagnosis, so the doctors kept investigating. Her urine carried the fingerprints of glutaric acid and 3-hydroxyglutaric acid. Plasma C5DC pointed to the same pathway. GCDH genetic testing provided the final confirmation. The most important lesson from this case is simple. The first reasonable diagnosis may not reveal the final cause. A patient may genuinely have bipolar disorder. At the same time, that patient may also have an inborn error of metabolism affecting the brain. When psychiatric symptoms, neurologic signs, cognitive abnormalities, and a distinctive MRI pattern appear together, the search for an underlying cause should not stop. Because the evidence left behind by a metabolic disease may be scattered across different medical specialties, and what ultimately changes the diagnosis is often not one dramatic symptom. It is the moment when all those previously unexplained details finally connect. Chapter 2. What exactly is GA1? In the previous chapter, 3 abnormal markers pointed to glutaric acidemia type 1, or GA1, glutaric acid, 3-hydroxyglutaric acid, and glutarylcarnitine, or C5DC. But why would all 3 rise at the same time? The answer is hidden inside the mitochondria. GA1 is also known as glutaric aciduria type 1. It is an inherited disorder of amino acid metabolism. GA1 has established protocols for metabolic management. When GA1 is identified and treated before neurologic injury occurs, the risk of severe neurologic damage can be substantially reduced. GA1 is caused by biallelic pathogenic variants in the glutaryl CoA dehydrogenase gene, known as GCDH. It follows an autosomal recessive pattern of inheritance. This usually means that a patient inherits one disease-causing GCDH variant from each parent. The parents themselves may have no symptoms at all. First, where does the GA1 pathway become blocked? When the body breaks down lysine, hydroxylysine, and tryptophan, these amino acids move through a series of metabolic steps. Those pathways eventually produce an intermediate compound, glutaryl coenzyme A, or glutaryl CoA. Under normal conditions, an enzyme called glutaryl CoA dehydrogenase continues processing it. That enzyme is encoded by the GCDH gene. Think of the pathway as a production line. The GCDH enzyme acts like one of its critical gates. When the gate works, metabolites keep moving down the line. When the gate fails, materials upstream begin to back up. That is when 3 important metabolic fingerprints appear: glutaric acid, 3-hydroxyglutaric acid, and glutarylcarnitine, or C5DC. The first 2 are usually detected through urine organic acid analysis. C5DC can be detected in dried blood spots collected for newborn screening or through plasma acylcarnitine analysis. These markers can point doctors in the right direction. But definitive diagnosis usually also requires GCDH genetic testing. If the genetic findings do not clearly explain the condition, glutaryl CoA dehydrogenase enzyme activity may also be measured. Second, breaking the metabolic block into 4 steps. Step 1, the raw materials enter. Lysine and related amino acids from food and from the body's own proteins enter the breakdown pathway. Step 2, an intermediate is formed. These pathways gradually converge on glutaryl CoA. Step 3, the pathway becomes blocked at the GCDH enzyme step. Glutaryl CoA can no longer be processed at the normal rate. Step 4, metabolites are diverted and begin to accumulate. Glutaric acid, 3-hydroxyglutaric acid, and C5DC rise as a result. Carnitine also binds to glutaryl groups to form C5DC. Over time, this may contribute to secondary carnitine deficiency in some patients. The balance of free coenzyme A inside the cell may also be affected, so the abnormal numbers on a laboratory report are chemical traces left behind by a blocked pathway. Finally, why does treatment target both the entrance and the exit? Dietary management mainly limits excess lysine entering the blocked pathway. LCarnitine helps glutaryl groups form C5DC, helping the body transport and eliminate some of the abnormal acyl load. It also helps maintain the intracellular balance of carnitine and free coenzyme A. One strategy controls what enters the pathway. The other helps the body clear what builds up. Both are aimed at the same goal, reducing the abnormal metabolic burden as much as possible. Chapter 3. Why is the brain so vulnerable? The neurologic injury doctors fear most in GA1 often centers on the striatum, especially the caudate nucleus and the putamen. That raises an important question. Why does GA1 not affect every part of the brain equally? Why is the striatum especially vulnerable? At this point, there is no single explanation that accounts for everything. But research has identified several possible clues. During infancy and early childhood, the striatum is developing rapidly. Its energy demands are high. Glutamate signaling is active. Excitatory signaling involving N-methyl-D-aspartate receptors, or NMDA receptors, may also contribute to neurologic injury. At the same time, the abnormal metabolites produced in GA1 may interfere with energy metabolism and nerve cell function. Together, these factors may create a particularly vulnerable window in early life. Why can an infection set off a crisis? In classic GA1, an acute encephalopathic crisis may occur during an infection, a fever, persistent vomiting, prolonged poor intake, or surgery. The infection is often only the trigger. What rises rapidly inside the body is catabolic stress. When a child cannot eat, the body still needs energy. So it begins breaking down its own stored tissues and proteins. That releases more lysine. The amount of material flowing into the blocked pathway then increases. At the same time, the child's intake of energy and fluids is falling. For someone with GA1, these pressures can occur together and rapidly increase the risk of neurologic injury. That is why emergency treatment during an illness cannot wait until obvious neurologic symptoms appear. The priorities are to provide adequate energy as early as possible, minimize fasting, limit catabolism, and follow the emergency plan created by the metabolic team. Age is another piece of the puzzle. The period of greatest risk for an acute encephalopathic crisis and striatal injury in GA1 is concentrated in infancy and early childhood. That risk falls substantially as a child gets older, but it does not disappear completely. At the same time, late-onset cases may present with a very different pattern. White matter abnormalities, structural changes in the frontotemporal regions, chronic neurologic symptoms, or peripheral nerve involvement. These findings may be related to long-term metabolic abnormalities, but the exact mechanisms are still not fully understood. Chapter 4. GA1 has more than one face. When many people think of GA1, they picture an acute encephalopathic crisis in an infant or young child, then striatal injury, and finally severe dystonia. But that is only one face of GA1. Some patients are identified through newborn screening before symptoms ever appear. Some never have a clearly recognized crisis, but gradually develop movement abnormalities. Others are not diagnosed until later childhood or adulthood, when headaches, tremor, seizures, cognitive changes, or abnormal findings on magnetic resonance imaging, or MRI, finally lead doctors to investigate further. Current literature generally defines the onset of clinical manifestations after age 6 as late-onset GA1, or LOGA1. Pathway 1. Detection through newborn screening of a dried blood spot shows elevated C5DC. Follow-up testing usually includes urine organic acid analysis, followed by genetic testing or, when needed, enzyme activity testing to establish the diagnosis. But in low excretors, screening markers may be less pronounced. As a result, some patients may still be missed by screening. Pathway 2. The acute encephalopathic form in infancy. After an infection, fasting, or another catabolic stressor, a child suddenly develops encephalopathy. MRI may reveal bilateral striatal injury. Dystonia and severe movement disorders may follow. Early in the course, this presentation may be mistaken for post-infectious encephalitis or another form of acute encephalopathy. Pathway 3. The insidious onset childhood form. These children may never experience one dramatic acute crisis, but their motor or neurologic function changes gradually over time. Because there is no obvious turning point in the course of the disease, the diagnosis is even more likely to be delayed. Pathway 4. The late-onset adult form. Late-onset patients may develop chronic headaches, tremor, pyramidal signs, peripheral neuropathy, seizures, cognitive decline, or unexplained abnormalities on MRI. Some patients appear to have no obvious symptoms at the time. They are identified only through family screening or after an abnormal result on their child's newborn screen. These symptoms are common, scattered, and may seem unrelated to one another. The basal ganglia may also remain normal, so the clinical picture often looks nothing like classic textbook GA1. Do high excretor and low excretor describe disease severity? No, that is not what these terms mean. High and low describe the biochemical excretion phenotype. They are not grades of disease severity. High excretors usually excrete larger amounts of glutaric acid and 3-hydroxy-glutaric acid. In low excretors, the elevations may be much smaller. Sometimes they may be close to the normal range. That is one reason low excretors are more likely to be missed by screening or remain undiagnosed. Low metabolite levels in the urine do not guarantee that the brain is protected. Without treatment, research has found that high excretors and low excretors have a similar risk of striatal injury. High excretors may be at greater risk of progressive white matter changes. But even that cannot accurately predict which symptoms one individual patient will develop in the future. Age is only part of the story. The presentation of GA1 can vary dramatically from one patient to another. Factors that may influence the course of the disease include how much residual GCDH enzyme activity the patient retains, the patient's biochemical phenotype, whether the patient has experienced metabolic stress from infection, fasting, or similar triggers, how early treatment began, and the individual course of that person's brain development. So an adult without the classic basal ganglia injury cannot be assumed not to have GA1. And when clinical suspicion is high, one unremarkable screening result should not bring the investigation to a premature end. The patients most likely to be missed are often the ones whose illness never followed the classic script. Chapter 5. In late onset, GA1, the most common clue, may be a headache. Some people with GA1 never experience the classic encephalopathic crisis of infancy. They may study, work, and go about daily life for decades. Then a headache, a neurologic examination, or an unexpected MRI finding reopens the diagnostic investigation. A 2026 scoping review brought together 53 reported patients with late-onset GA1. 24 appeared to have no obvious symptoms. They were identified through family screening or through their child's newborn screening results. The other 29 entered the diagnostic process because they had developed symptoms. Their ages at diagnosis ranged from 8 to 71 years. The onset was usually gradual. The symptoms were generally mild, and the most frequently reported symptom was headache. Recurrent or chronic headache is a clinical clue worth noticing in late-onset GA1. Other non-specific findings may include vertigo, ataxia, tremor, seizures, and cognitive decline. But each of those symptoms is common on its own. What makes GA1 more plausible is the combination of those symptoms with abnormal neurologic signs or a distinctive MRI pattern. Adult MRI may not show the classic striatal injury. A 2017 case series compared 8 late-onset patients with 8 patients who had been diagnosed and treated early. None of the patients in the late-onset group had dystonia, and none had striatal lesions on MRI. But all late-onset patients had frontotemporal hypoplasia and white matter changes. 6 also had subependymal lesions. This is exactly why late-onset GA1 can be missed. If a doctor looks only for the classic basal ganglia injury seen in young children, an adult patient may be overlooked. MRI findings that deserve attention in late-onset GA1 include frontotemporal hypoplasia or atrophy, widened sylvian fissures, widened opercula, periventricular or other white matter abnormalities, and subependymal nodules. Some patients may also have cerebral atrophy, enlarged ventricles, subdural fluid collections, or subdural hemorrhage, but no patient will necessarily have every one of these findings. MRI findings in GA1 vary widely. The basal ganglia may look completely normal in an adult patient, so the absence of striatal lesions cannot rule out late-onset GA1 on its own. There is another contrast that can be confusing. Some patients have striking abnormalities on MRI, yet their everyday cognition and ability to function remain close to normal. One possible explanation is that the developing brain has some capacity to reorganize and compensate. Structural abnormalities that develop slowly may allow time for partial functional adaptation, but that explanation still needs support from more long-term research. Chapter 6. The abnormalities you may not notice in everyday conversation. Cognitive changes in late-onset glutaric acidemia type 1, or GA1, are often subtle. A patient may speak normally, work normally, and live independently. During a brief clinical visit, a doctor may not notice any obvious problem. Only when detailed neuropsychological testing begins do subtle deficits in specific areas emerge. Most reported patients with late-onset GA1 have had generally preserved overall cognitive function, but a small number have shown problems with attention, executive function, working memory, learning new information, verbal fluency, or fine motor skills. Progressive cognitive decline and dementia have also been reported in some older patients. Individual case reports have described difficulty regulating emotions, behavioral changes, and diagnoses of bipolar disorder or schizophrenia. The cognitive gaps often involve frontal executive networks. One 56-year-old man had impaired executive function and working memory. He also had difficulty learning new information. He scored 25 out of 30 on the Mini Mental State Examination, or MMSE. Magnetic resonance imaging, or MRI, showed communicating hydrocephalus, bilateral frontotemporal atrophy, and prominent abnormalities in the periventricular and deep white matter. A 32-year-old woman had reduced verbal fluency and impaired motor sequencing. A 16-year-old girl had mild difficulties with attention, executive function, and fine motor skills. Her MRI also showed injury to the putamen and diffuse white matter abnormalities in both frontal lobes. A small number of middle-aged and older patients have developed progressive memory loss, reduced speech, or dementia. These changes have often appeared alongside tremor, seizures, or other neurologic signs. In some studies, the weaknesses found on testing have echoed structural findings in the brain. These include reduced volume of the supramarginal gyrus, abnormal development of the temporal pole, and frontotemporal atrophy. That connection makes sense because the frontotemporal regions and white matter networks support attention, planning, language organization, working memory, and behavioral control. When these networks are affected, a patient may not show a broad decline in intellectual ability. They may simply take longer to find a word. They may have trouble sequencing movements. They may lose focus more easily, or they may find it harder to learn new information than they once did. Objective motor signs can reopen the investigation. Late-onset GA1 may also cause tremor, ataxia, pyramidal signs, abnormal eye movements, spastic diplegia, difficulty with motor sequencing, seizures, or peripheral neuropathy. Headaches and mood symptoms are both common. On their own, they are not specific to GA1. But if they occur alongside pyramidal signs, ataxia, abnormal eye movements, or other objective neurologic findings, the investigation should widen. For an adult who has been treated for years for migraine or a psychiatric disorder, these signs may be the clue that reopens the search for a metabolic diagnosis. Chapter 7. How might GA1 affect headaches, cognition, and mood? Headaches, cognitive abnormalities, and psychiatric diagnoses have all been reported in people with GA1. The mechanisms that follow describe biological possibilities. They do not prove what caused a particular symptom in an individual patient. Pathway 1. Metabolites may become trapped in the brain. Deficiency of glutaryl dehydrogenase, or GCDH, causes glutaric acid, 3-hydroxyglutaric acid, and glutarylcarnitine, or C5DC, to rise. Animal studies and blood-brain barrier models suggest that glutaric acid and 3-hydroxyglutaric acid have a limited ability to cross the blood-brain barrier. This means that some metabolites produced inside the brain may not leave the central nervous system easily. They may be retained and accumulate there. But researchers are still studying how much this trapping matters at different ages in humans. It may partly explain one clinical observation. Metabolite levels in blood or urine do not always match the degree of brain injury. Low urine levels do not guarantee that there is no metabolic stress inside the brain. Pathway 2. The balance between glutamate and GABA may be disrupted. Glutaric acid and 3-hydroxyglutaric acid share certain structural features with glutamate. Cell and animal studies suggest that, under specific experimental conditions, 3-hydroxyglutaric acid may produce excitotoxic effects involving N-methyl-D-aspartate receptors, or NMDA receptors. These metabolites may also indirectly interfere with neurotransmission involving glutamate and gamma-aminobutyric acid, or GABA. Glutamate primarily promotes neuronal excitation. GABA helps prevent excessive excitation. When that balance becomes unstable, neural networks may be more likely to lose their normal rhythm. This leads to two possible hypotheses. Abnormal regulation of neuronal excitability might lower the threshold for recurrent headaches or migraine-like episodes. An imbalance between excitation and inhibition in prefrontal and limbic networks might also affect executive control and mood stability. But these ideas still come from experimental evidence and mechanistic inference. Clinical studies have not directly confirmed them. Pathway 3. The brain may have less energy in reserve. Experimental studies have also found that GA1-related metabolites may interfere with mitochondrial energy metabolism. They may reduce phosphocreatine reserves, disrupt redox balance, and interfere with metabolic support between neurons and astrocytes. The brain has almost no long-term energy reserves. It is highly sensitive to changes in energy supply. Infection, fever, fasting, and repeated vomiting all increase catabolic stress. If nerve cells already have little energy in reserve, these events may amplify fluctuations in neurologic function. This pathway may help explain why symptoms worsen during infection or fasting in some patients. It also offers one possible explanation for susceptibility to headaches in GA1. Pathway 4. Oxidative stress may amplify the injury. Mechanistic research in GA1 has also suggested that oxidative stress, inflammatory cytokines, and nitric oxide may contribute to secondary injury. In theory, these signals could affect neuronal excitability, energy supply, vascular regulation, and pain networks. But there is currently no evidence that nitric oxide or inflammatory pathways are the direct cause of recurrent headaches in GA1. They remain candidate mechanisms. Pathway 5. Frontotemporal and white matter networks may be altered. Late-onset GA1 has repeatedly been associated with frontotemporal hypoplasia, frontotemporal atrophy, and symmetric white matter abnormalities. White matter acts like a communication system connecting different regions of the brain. Connections among the frontal lobes, orbitofrontal cortex, anterior cingulate cortex, temporal lobes, and limbic system support many higher functions. Attention, planning, language organization, working memory, behavioral inhibition, and emotional regulation. When these networks are affected, a patient may develop reduced verbal fluency, difficulty carrying out motor sequences, weaker attention and working memory, slower learning of new information, or less stable emotional control. This explanation fits with the cognitive testing and MRI findings described in individual cases, but there is still not enough functional imaging, tractography, or long-term neuropsychological follow-up to confirm the full picture. Pathway 6. Carnitine helps divert the metabolic load. Glutaryl groups can bind to carnitine to form C5DC, which can then be excreted. Over time, this process may deplete the body's carnitine stores. The continued accumulation of glutaryl CoA may also disturb the balance of free coenzyme A inside the cell. Levocarnitine can replenish carnitine in patients with secondary deficiency. It also promotes the transport and elimination of glutaryl groups in the form of C5DC. That is the biochemical basis for using levocarnitine in GA1 management. So when should late-onset GA1 truly enter the differential diagnosis? A headache by itself is usually not enough to suggest GA1. Psychiatric symptoms alone are also not enough. What deserves attention is the appearance of several findings that do not ordinarily belong together. Abnormal neurologic signs, declining executive function, symmetric white matter disease, abnormal frontotemporal development, a history of macrocephaly in childhood, neurologic worsening after infection or fasting, or a GCDH-related clue found through a child's newborn screen or family testing. When these pieces come together in the same patient, GA1 should enter the diagnostic picture. Chapter 8. Diagnosis. Tightening the net. GA1 cannot be confirmed with one test alone. Screening provides the first clue. Metabolites narrow the possibilities. MRI reveals a pattern. Genetic or enzyme-based evidence provides confirmation. Step 1. Newborn screening looks for C5DC in regions that include GA1 in newborn screening. The earliest clue usually comes from a heel stick blood sample. The laboratory uses tandem mass spectrometry to measure C5DC in a dried blood spot. An out-of-range screening result requires prompt follow-up. That evaluation commonly includes quantitative urine organic acid analysis, an Acylcarnitine profile from plasma or another dried blood spot, and molecular genetic testing. Low excretor GA1 is more likely to be missed by newborn screening. One German cohort included 87 patients detected through screening and 4 patients who had been missed by screening. The study estimated an overall screening sensitivity of 95.6%. For low excretors, it was approximately 84%. So a normal newborn screen can make GA1 much less likely. But when clinical suspicion is high, a normal screen alone cannot completely rule it out. Step 2. Look for the metabolic fingerprints. In a patient with symptoms, 3 markers deserve particular attention: glutaric acid in the urine, 3-hydroxyglutaric acid in the urine, and C5DC in plasma or a dried blood spot. In low excretors, the urine abnormalities may be very subtle. Doctors may also measure total and free carnitine. This can show whether secondary carnitine deficiency is present and provide a baseline for treatment monitoring. Metabolite levels can point the investigation in the right direction. They cannot establish the diagnosis by themselves. These results may be influenced by other disorders: kidney function, nutritional status, sample quality, and the testing method used. That is why laboratory findings must be interpreted alongside the patient's age, symptoms, MRI, and complete metabolic profile. Step 3. Look for 2 disease-causing GCDH variants. When the clinical and biochemical findings fit, biallelic pathogenic or likely pathogenic variants in GCDH can establish the diagnosis. Testing usually begins with sequencing of the GCDH gene. Deletion and duplication analysis may be added when necessary. When the phenotype is unusual, doctors may use a multi-gene panel for inherited metabolic disorders or exome sequencing. Finding only one pathogenic variant is usually not enough. Finding 1 or 2 variants of uncertain significance, or VUS, does not automatically confirm GA1 either. A VUS means the evidence is still uncertain. It is not a diagnosis. Step 4. When genetics is unclear, enzyme activity can add functional evidence. If the biochemical evidence strongly suggests GA1, but genetic testing does not provide a clear answer, a specialized laboratory can measure glutaryl-CoA dehydrogenase enzyme activity. Samples may come from cultured skin fibroblasts or white blood cells, also called leukocytes. Significantly reduced enzyme activity can provide critical functional evidence. The metabolic genetics team should determine which type of sample is appropriate. MRI provides a pattern, not a definitive diagnosis. Widened opercula, frontotemporal hypoplasia, basal ganglia injury, white matter abnormalities, and subependymal lesions. Each of these findings can point toward GA1, but none is unique to GA1. Late-onset patients may also have normal basal ganglia, so MRI helps establish the direction of the investigation. Confirmation still depends on biochemical, genetic, or enzyme-based evidence. Elevated glutaric acid does not point to only one disease: glutaric acidemia type 1, glutaric acidemia type 2, 2-hydroxyglutaric aciduria, and SUGCT-related glutaric aciduria type 3. These are not the same disorder. They involve different genes, enzymes, and metabolic profiles. The full urine organic acid profile must be reviewed. It must be combined with the Acylcarnitine pattern, clinical findings, and genetic results. Seeing elevated glutaric acid is not enough to write down GA1 as the diagnosis. Chapter 9. The most important time to treat is before injury occurs. In GA1, the most important window for treatment is often before injury occurs. Newborn screening. Diagnosis before symptoms appear. Age-appropriate dietary management. Leukodystrophy. And prompt use of an emergency protocol during illness. Together, these measures have significantly improved outcomes for children with GA1. Once striatal injury and a complex movement disorder have developed, they are usually difficult to reverse completely. That gives prevention far more weight than treatment after the injury. Forcing every metabolic marker into the normal range is not the goal. The goal is to reduce the risk of neurologic injury and preserve long-term function as much as possible. First, control the lysine load. Precisely. A low lysine diet does not mean cutting protein lower and lower. Children under age 6 usually need a diet designed by a metabolic dietitian specializing in inherited metabolic disorders. That plan may include a specialized amino acid formula that contains no lysine and a reduced amount of tryptophan. Natural protein must still be carefully calibrated to meet the child's growth needs. Tryptophan is an essential amino acid. It cannot be removed completely. After age 6, management usually shifts toward controlling the amount of natural protein and limiting foods with a high lysine load. The plan is then individualized according to age, nutritional status, and metabolic needs. Too much protein increases the amount of substrate entering the blocked pathway. Too little protein can also be dangerous. Excessive long-term restriction may cause malnutrition. If the body begins breaking down its own tissues, it releases even more endogenous lysine. That is why long-term GA1 management cannot be based on an online list of foods to avoid. It requires ongoing assessment of growth, weight, dietary records, amino acid levels, and other relevant nutritional markers. Second, use age-adjusted LCarnitine. Dosing LCarnitine promotes the formation of C5DC from glutaryl groups. This helps transport and eliminate the abnormal acyl load. It also lowers the risk of free carnitine deficiency. Guideline reference ranges for routine oral dosing decrease with age. From birth through 47 months, the reference dose is approximately 100 milligrams per kilogram of body weight per day. From 48 through 72 months, it is approximately 50 to 100 milligrams per kilogram per day. After age 6, it is approximately 30 to 50 milligrams per kilogram per day. One important caution: these are guideline reference ranges. They are not prescriptions that can be copied for every patient. The actual dose, dosing schedule, formulation, and monitoring plan must be determined by the metabolic team. Third, during illness, stop the body from breaking down its own protein fever. Repeated vomiting, diarrhea, a major drop in food intake, surgery, or prolonged fasting. Any of these may require activation of a written sick day emergency plan. If symptoms are mild and the patient can still eat, the specialist plan may call for more carbohydrates and fluids. Natural protein may be temporarily reduced. Leukodystrophy may also be adjusted according to the plan. If the patient cannot maintain intake, continues to vomit, develops a change in mental status, or shows new neurologic symptoms, they should go immediately to a hospital equipped to manage metabolic emergencies. The priority in the hospital is to reverse catabolism quickly. The medical team may use intravenous fluids containing glucose. Insulin may be added when necessary. Intravenous lipids may also be used to provide additional energy. Natural protein may be reduced or briefly withheld, but it usually needs to be reintroduced promptly. Leukodystrophy may also be increased according to the emergency protocol. The glucose concentration, infusion rate, insulin dose, and LCarnitine dose must be calculated from the patient's weight, blood glucose, circulatory status, and laboratory results. Online dosing instructions must never be copied and used at home. Metabolic risk does not end in adulthood. After age 6, the risk of the classic acute striatal crisis drops substantially. But a severe infection, prolonged fasting, trauma, childbirth, anesthesia, or the perioperative period can still create significant catabolic stress. Adolescents and adults may therefore need an age-appropriate emergency plan in these situations. Growing older does not automatically mean that the metabolic risk is gone. Existing neurologic symptoms still require symptomatic treatment and rehabilitation. Metabolic management cannot replace treatment for symptoms that are already present. For dystonia, a movement disorder specialist may consider benzodiazepines, baclofen, trihexyphenidyl, or botulinum toxin type A, depending on the patient's needs. Seizures require an anti-seizure medication selected according to the seizure type. Physical therapy, occupational therapy, and speech and swallowing evaluations should also begin early. Patients with severe movement disorders also need measures to prevent aspiration, pain, hip complications, and malnutrition. Late-onset patients also need psychiatric and cognitive follow-up. If mood episodes, anxiety, behavioral changes, or cognitive decline appear, psychiatrists and neuropsychologists should evaluate and treat them according to standard clinical practice. GA1 metabolic management must continue as well. Neither form of care can replace the other. Long-term monitoring should look beyond the brain. A1 may also affect the kidneys. Chronic kidney disease has been observed in adults. Current recommendations call for kidney function to be evaluated at least once a year, beginning at age 6. That assessment includes markers such as creatinine and cystatin C. Nutrition, motor function, neurologic function, development, and cognition also require continued follow-up. Some laboratory markers are useful for diagnosis but cannot reliably measure how well a patient is doing. Urinary glutaric acid and 3-hydroxyglutaric acid do not consistently correlate with clinical outcomes. C5-DC is also affected by LCarnitine treatment. Long-term treatment should not be increased or reduced based on these numbers alone. Which treatments still lack reliable evidence? The words metabolic disease can make people think of many different supplements. But more supplements do not necessarily mean better treatment. Riboflavin is not currently a standard treatment for GA1. Antioxidants, creatine, N-acetylcysteine, and glutamate antagonist strategies still lack reliable evidence from clinical outcomes. Topiramate may be used for a standard indication, such as migraine or epilepsy, but there is no evidence that it corrects the metabolic defect in GA1 or improves the long-term outcome of GA1 itself. GA1-specific formulas that contain arginine may be part of a professionally supervised dietary plan. Taking additional free arginine on your own is not part of routine recommendations. Conclusion. What did this 32-year-old woman ultimately teach us? A1 is easy to miss because every clue looks ordinary on its own. Headaches can be labeled as migraine. Mood swings can remain in the psychiatric record. Subtle pyramidal signs may be overlooked. White matter abnormalities may first be described as nonspecific changes. When those fragments are scattered across different years, different hospitals, and different medical specialties, a metabolic disease has room to remain hidden in the background. The breakthrough comes from combining the clues. Chronic headaches or psychiatric and cognitive changes, together with objective neurologic signs. Frontotemporal changes or symmetric white matter disease, together with abnormal glutaric acid, 3-hydroxyglutaric acid, or C5DC. Finally, confirmation comes from biallelic pathogenic variants in GCDH, or significantly reduced glutarylCoA dehydrogenase enzyme activity. Clinical symptoms sound the alarm. The neurologic examination finds the abnormalities. MRI draws the map. Metabolites leave chemical fingerprints, and genetic or enzyme-based evidence finally confirms the identity of the disease. This woman, diagnosed with GA1 at age 32, leaves us with one essential lesson. When a common diagnosis cannot explain all the objective abnormalities, the investigation should not stop. Doctors need to keep asking, has an inherited metabolic pathway been missed? One that can be tested, one that can be managed, and one that may also matter for other members of the family. That question deserves serious consideration, especially when a patient has abnormal neurologic signs, cognitive changes, symmetric white matter disease, or neurologic worsening during metabolic stress such as infection or fasting.